Owners of the lands on which we meet today, and pay our respects to elders past, present and future, for they hold the memories, the traditions, the cultures and hopes of Aboriginal Australia. So just some general housekeeping. If you have any questions throughout today's session, please pop them in the chat or Q&A. And if we have time, we will try to answer these at the end. Any questions we don't get to answer, I will get PHU to respond, and I will send the answers out with the slides and the recording of this webinar. We appreciate if you can complete the evaluation form that will open up when you leave the session, just to ensure we continue to provide relevant information for you. As I mentioned, we will be recording today's session, and you will be provided a copy of this recording along with your certificate of attendance and the slides. These will be sent out to the email address that you registered within the next couple of weeks. Just please be aware that each state has a different immunisation program governed by their state public health unit. So the information provided by the Queensland Health Public Health Unit may not be relevant to some people attending from other states. The information provided at this webinar is specific to Queensland, and we recommend that you check with your local state public health unit for localised information. All information provided in today's session is current as at today. Please refer to the public health unit if you have any queries. Their contact number is 07 3624 1111. And now I will hand you over to Emily Titmus, the public health nurse from the Metro North Public Health Unit, to present today's session. Over to you, Emily.
Thank you, Amy. I'm just going to share my screen. Just one sec. Okay, hopefully everybody can see that now.
Yep, we can.
Coming out?
Yes, we can.
Okay.
Thank you.
Okay, great. All right, thanks everybody. So I just wanted to sort of start by saying today that there's a lot, I'm sure you don't need me to tell you that there's a lot going on in immunisation. So this is there's a lot in this presentation. So hopefully the information is relevant and helpful to you. It was updated as early as today because things are sort of moving feast a little bit at the moment with immunisation. Okay, so we'll start with what's new, some updates, some reminders, a little bit about influenza, the updated booster guidelines for COVID, about vaccine administration errors, recommended and funded vaccines, a little bit about travel vaccines as well, and a couple of slides on catch up too. Okay. I'm going to start with RSV because obviously there's been a lot happening in this space in the last couple of weeks. So RSV is a virus that causes respiratory infection, and the rates of infections in Queensland are usually higher in autumn and during winter. Young infants, babies and older people are at higher risk of severe illness. It's notifiable in Queensland and in other states as well. And it's the most common cause of hospitalisations for infants and young children. So about 3% of all children between about 0 and 2 years of age are admitted to hospital with RSV in Australia. Luckily for us, the numbers of deaths are low, but that is not the same experience in other low and middle income countries. Almost all children will experience at least one RSV infection within that first 2 years of life. Prevention is similar to other respiratory illnesses in terms of those public health messages such as cover your cough and stay at home when you're sick. I'll start with the vaccine that's been approved for older people. So the TGA approved this GSK vaccine in January. I'm not quite sure how to pronounce it, but I think it's AREXV or something like that. It's just a single dose IM injection, and it's indicated for individuals 60 years and over to prevent those respiratory infections from RSV. It's obviously only available at the moment on the private market, and I've just popped a link to a fact sheet, an NCIRS National Centre for Immunisation Research and Surveillance fact sheet about RSV that mentions this particular vaccine as well. In terms of other vaccines, so just recently at the end of March, another vaccine was approved. Again, not quite sure how to pronounce that name, but it's to be given in pregnancy to protect infants, so given to pregnant women to protect infants when they're born. So that's now TGA approved. And there's another one, a Moderna vaccine that's also currently sitting with the TGA under evaluation. So we're just waiting to see what the outcome of that one will be. So this is an area where there's going to be further updates as time goes on. So I guess probably most importantly is that you would have, I'm sure, been aware that yesterday that it was the commencement of the Queensland Paediatric RSV Prevention Program. So this is a Queensland program. It's not a national program at this point in time. There's a couple of other states that have introduced a similar program as well, WA and I think South Australia. It will provide pre-immunisation to eligible Queensland infants and young children, and the aim is to protect infants and those at risk of severe disease, and I guess in turn to decrease, or hopefully to decrease RSV associated hospitalisations. It provides passive immunisation, so it contains pre-made antibodies, monoclonal antibodies that can prevent against RSV. And it provides a protection almost immediately, and for about 5 months is what the research indicates. This immunisation has been used overseas previously. So overseas programs and clinical trials show that its effectiveness, and also that side effects are uncommon and mostly mild, usually things like soreness, redness and swelling at the injection site, and sometimes fever and rash. It'll be administered in hospital for all newborn babies. Further information will be available shortly, hopefully, with regard to access in the primary care setting for high-risk children who didn't receive it in hospital, or for any children born from the 1st of February this year who didn't receive it in hospital. It'll be given at the same sort of time as the vitamin K and the birth dose Hep B in the maternity units. All providers were sent some communication yesterday, so please just ensure that you have an up-to-date email address with QUIP, because all of the details about this program were distributed by email yesterday to all vaccine service providers. So as we mentioned, the program commenced yesterday and catch up from the 1st of February. Children can access a dose if they didn't receive it in hospital up to less than 8 months of age. And children with certain complex medical conditions from 8 to 19 months of age. So more details about eligibility are available in that link that I just sent, I've got written there. So have a look at that website. There's also, on that website, there's also a clinical guidelines document that's been updated just yesterday, I believe. And then it talks about eligibility, recommendations, administration and things like that. And also a little bit about what the product looks like and how it's administered as well. So it's really quite a good guideline. It can be given, and the guideline mentions this, that this immunisation can be given to infants who had previously had laboratory confirmed RSV if they're eligible. Okay. So this slide is really a summary of what's happening in this space, really. So it mentions the different available products, if they've been approved or submitted to the TGA for approval, and how they're being funded. And you can see there, New South Wales, sorry, Queensland and Western Australia, not South Australia, it's New South Wales, who are currently involved in a state-funded program for the monoclonal antibodies that we were just discussing. There's going to be updates made to the handbook probably in May, and there's already an ATAGI statement that's available about RSV as well. There's also been an update, we've just heard just this morning, to the immunisation schedule to include RSV immunisation. I've also included on this slide a QR code to a CDC study, which demonstrated monoclonal antibodies having about a 90% effectiveness in reducing RSV-related hospitalisations. And we are sort of using some of the learnings and the evidence from overseas to consider how we've used these products in Australia. Okay, on to Q fever. So I'm not sure if you are aware about the closure of the Australian Q fever register. This register was a vaccine register which was administered by a private provider. So that's going to be closed, and from Monday, providers can report Q fever to AIR now, which is great. Hopefully that means that AIR is going to be sort of more of a one-stop shop. So what the recommendation is that individuals take copies of their Q fever vaccination records to providers who can then upload to AIR for them. If they don't have copies, they're still able to obtain an e-statement of their vaccination records from the Q fever register at this point in time. So just another thing to consider in terms of uploading those vaccines to AIR rather than the Q fever register. Okay. So I'll move on to measles, and you might be maybe wondering a little bit about why this is included in the slide. It's very topical at the moment, this disease, because there's been a stark increase in cases post-COVID. Probably there's a probably a few different reasons. One of them is we're seeing some vaccine hesitancy in general post-COVID, but also there's been difficulties with accessing vaccines during COVID. And then when we think about the UK experience, which is what this slide is about, you could also consider that you may recall that there was some issues around a publication which was withdrawn around MMR and a link to autism, which was actually completely withdrawn and considered not correct. So that's probably why there's some issues, particularly in the UK. So there's been a very big outbreak in the Midlands of the UK and in kind of Birmingham area. There's been huge numbers of cases. There's been a death. In the UK at the moment, they're saying that there's about 1 in 10 children who will start school without having protection from measles. And there's been a lot of work in the UK to try and improve this situation. So we've also had cases that you're probably aware of in New South Wales, Victoria, and also on the south side of Brisbane. Gold Coast as well has had cases this year too. So there's a lot of measles around. As you're aware, 2 doses of MMR vaccine are funded for children and anyone born during and since 1966 as well. However, children who have received children are eligible to receive a dose of MMR from 6 months of age, but at less than 11 months of age if they've been exposed, for example, or they're travelling overseas. So that dose is funded. So for those children, 3 doses in total is funded. They have the one that they've had prior to 11 months of age, and then they follow the schedule after that and have 2 further funded doses. It's important for practices to sort of opportunistically check vaccination status of all of their patients to make sure that they've got 2 documented doses of MMR on board. So as we talked about before, there's some new immunisation schedules that were initially updated in February and then have been recently updated this morning as well to include RSV. So these new Queensland schedules include all of the new aspects to the program, essentially. So Bexsero, Shingrix, the flu information, and RSV. There's three schedules. So the children and the adolescents and adults and medically at risk as well. So just a note, we sometimes still get some requests for printed versions of the schedule, but unfortunately they're no longer, the immunisation program no longer prints in bulk. So it is really just about accessing the schedule online. And I guess just a reminder that because I think Amy mentioned this as well at the beginning of the presentation, there's a national immunisation program schedule available online, but because the immunisation program changes or it differs from state to state, it's important in terms of routine vaccinations to use the Queensland schedule. So, for example, RSV will be different, meningococcal B will be different in the other states as well. I would also just want to make a point about the online version of the Australian Immunisation Handbook. The handbook is, as you know, is regularly updated. So I guess we would really discourage the downloading and printing of the handbook, because if you use that, there's a risk there that you are not using the most up-to-date version of the handbook. I just wanted to include a slide as well on Shingrix. As you're aware, Shingrix is a reactogenic vaccine, and we know that. So prior to the introduction of Shingrix, studies had reported about an 82% reaction percentage or rate. I just wanted to add this slide because recent AUSVAC safety data indicates that from about 27,000 surveys, about 48% of recipients indicated an adverse reaction or a reaction. And I think it's just important to ensure that as health professionals that we're, advising patients of this prior to administering the Shingrix to expect a reaction, because we want patients to have, the 2 doses and to ensure that they're adequately protected and they've got an adequate duration of protection as well. This information is available online from AUSVAC Safety if you would like to have a look at it, and there's a link down the bottom to the immunisation program advice or guidelines, clinical guidelines for providers around Shingrix. Okay, so I'll talk now about the influenza, and COVID vaccine immunisations. So, we have, as you know, we've had a free flu program for Queenslanders for a couple of years now. I think this is the 3rd year from 6 months of age. This year on the NIPS schedule, there's a new cell-based vaccine called FluCellVax. It's just a different way that they make the vaccines. Most of the inactivated flu vaccines that we use are produced by growing flu viruses in eggs, and this one is used. The virus is grown in cultured cells of mammalian origin rather than the eggs, the hen's eggs. I just wanted to also add a couple of points about this particular vaccine. So there's on the packaging that you will receive from the National Immunisation Program via QIP, there's a little sticker on there that says that it's for 6 months and onwards, but under the National Immunisation Program schedule, it's funded for 5 years onwards. So that's just been something that's been raised with us, just to watch that packaging sticker. Also important to note that ATAGI indicates or recommends that there's no preferential recommendation between this cell-based vaccine, FluCellVax, and any other standard dose of egg-based influenza vaccines. You'll be aware as well that adults aged 65 years and over should be having that adjuvanted vaccine Fluad Quad, which we've had on the program for a while, and that's recommended over any other vaccine. And just a note about co-administration. So influenza vaccines can be given at the same time or at any interval before and after other vaccines, including all of those vaccines that are listed there. And that information about co-administration is in the handbook if you need a reference for that one. So for this year, in terms of precautions for our 2014 vaccines, they're all latex-free under National Immunisation Program schedule, so people with a latex allergy can be safely vaccinated. And just a note, I know this has been in the handbook for a couple of years now though, but allergy to eggs is not a contraindication to egg-based vaccines. If you are particularly concerned about somebody, you can just ensure that they stay behind after vaccination for an additional 15 minutes over and above what you would usually recommend they wait with you for. So just a couple of links to some documents, some guidance documents. That's the ATAGI statement that they release every year for seasonal influenza vaccines. And another guideline document from the Commonwealth as well. Just wanted to include this information that's actually available on the website. There's quite a lot of information on the website with regard to reimbursement for vaccines purchased by providers and administered to those people who don't meet the eligibility requirements for the National Immunisation Program vaccines. So the recommendation on this website from the immunisation program is that submission for reimbursement should be made no more frequently than fortnightly. I guess the cessation of the program in terms of reimbursement for the year is the 30th of September. There's a lot of requests at the moment for reimbursement, so just to be aware that if you do submit a request, that there might be some delays. And if you have any questions specifically about reimbursement and that sort of thing, please utilise the email on the screen. Public Health can assist you to some degree around these sorts of things, but really if it's to do with reimbursement or follow up about reimbursement, the queries really should go to the immunisation program. Just one slide about COVID-19 booster. So I won't read that all out, but it's actually probably a little bit clearer to me than previous versions of this booster guide. So hopefully this is taken straight from the web page, and if you click on the QR code, it'll take you to the web page. I think it's probably, as I said, a little bit clearer than previous versions of these booster guidelines. Just a couple of updates around pharmacy. There's a new order form which includes MMR for pharmacists and also meningococcal B. There's a really useful website as well that's been set up, you're probably aware, that has more details and information about pharmacy-specific immunisation on the program. Sorry, just... Okay, there's some, the next two slides are around reimbursement types and how to claim reimbursement for specific parts of the program and dependent on which vaccine you'll be administering. And this has come from the immunisation program. It's a little bit of a guide about using this particular program to claim the free flu reimbursement. Just a general update as well for all BSPs. If your vaccine delivery hasn't been packed appropriately and you're concerned and you think that the cold chain has not been maintained, don't use the vaccines. Cohort them or isolate them in your fridge and complete a vaccine delivery report form and email it to the immunisation program. And QIP will then respond with some advice. Usually those sorts of situations also are referred to the public health unit for some advice, and we can have a chat to you about what happened and how we could assist you. If you do need to also transfer or discard vaccines, please complete the form with the link on your screen there. If you are going to be transferring vaccines and you need some support around managing cold chain as first strive for 5, you can always give us a call as well before you're going to do that, and we can assist you with how to best make sure to try and avoid a cold chain breach as best as possible. Oh, that's the updated order form. So just be careful that you're using the updated order form. I think it's been updated a couple of times already this year. So just always access the order form on the website. And obviously now it includes flu, all of the flu vaccines as well. Okay. I'm going to talk now about vaccine administration errors. And there's a couple of reasons for that. One is that, as we mentioned before, really our immunisation schedule is becoming more and more complex, and I think that probably introduces more opportunity for errors. And I think the other thing is that we've just adopted a slightly different way of reporting vaccine administration errors. And it's not just reporting and discussing with your local public health unit. There's also a requirement to complete a form for those errors, but I'll get to that in a second. So a vaccine administration error occurs when the vaccine is essentially incorrectly prepared, administered, or stored, and it's outside a clinical guideline. It can then result in an adverse event, and not always. They're two separate things. So administration errors and APHIs are two separate things, but sometimes vaccine administration errors can result in an adverse event as well. I've just documented on this slide the sort of things that we experience or that we're asked about in terms of vaccine errors. So an expired vaccine. So sometimes, perhaps if stock rotation hasn't happened or something like that, an expired vaccine will be administered. So we've had a few situations recently where vaccine have been administered after a cold chain breach has occurred. The third dot point happens a little bit. So it happens when the two parts of the vaccine are not administered, but they're not both administered. So either one or the other is administered. So that can happen sometimes with Hexa and Nimenrix. And I think that's something that we have to watch now that we've got Vaxelis on the schedule, that, we've got Vaxelis in the stock as well. So, which doesn't require that, that diluent to be, or the Hib pellet to be mixed with the rest of the vaccine. Vaccine errors that occur because the vaccines are administered outside the recommended age, and probably the most common one is rotavirus with that one. Minimum interval not observed. That happens also reasonably regularly. And then the other thing we see is the wrong route or technique being used, resulting in a vaccine administration error. So if you give us a call about vaccine administration errors, this is essentially what we'll talk you through. So we always recommend open disclosure, so advising the parents and the patients as soon as possible, and being open and honest about the error and how you're going to fix it. It's important to investigate it and identify the cause, to look at how it can be prevented, and then follow your usual internal processes with regard to reporting errors and supporting staff. And one of the most important things is to keep up to date as best as you can. And I do acknowledge, obviously, that things are a moving feast in immunisation, and sometimes that can be hard, particularly when you're busy. And one of the things that we always say if vaccine errors are reported to us is that we all make mistakes, and sometimes these things do happen. So it is important to support each other if errors do occur. And that's what we're here for too. We're always here to support you and provide advice. So we're more than happy for you, and we're happy to continue to contact us for advice regarding vaccine administration errors, and we can help with issues such as if revaccination is required. That's not always the case, but sometimes it is. Now, this is where it gets a bit tricky. We do now recommend that you report the vaccine administration errors formally. So what's happened is that the adverse event following immunisation form that's online, that you would usually use to report your APHIs, now also has a tick box for vaccine administration errors. So even though this form is called adverse event following immunisation form, we do request that you utilise this form to report vaccine administration errors as well. So this information or data is collated in one of our databases. Other states have been kind of doing this in terms of formal reporting of vaccine administration errors for some time. So it's not something sort of new in other places in Australia, but it's only sort of recently been required here in Queensland. So I've just included these 6 rights of medication administration, which might also help you as well in terms of things to remember when you're giving immunisations and how to prevent vaccine administration errors. So what we would usually recommend is to check the patient details and vaccination history first. Do that 6-step check, including a 2-person check. So we always would recommend a 2-person check. I know that sometimes there's situations where that's going to be a little bit difficult, but hopefully there's always going to be a nurse and a doctor there, or 2 nurses or something like that on site that you can do a 2-person check. We always recommend using the pre-vaccination checklist, always checking the correct vaccine route, dose, intervals, and age. And the intervals can be found in the front of the handbook in the catch-up section. There's intervals table, or you can give us a call if you need some help. Sometimes errors are to do with the way that the vaccines or the vaccines are sort of organised in their baskets and labelled and that sort of thing. So we would always sort of recommend making sure that your fridge is labelled and organised so that to try and prevent any errors, and obviously regular stock rotation. The other thing that we do recommend is that perhaps if the administration staff at your service can assist you by asking patients when they make an appointment what they're attending for, and so that clinical staff can prepare in advance if patients are attending for vaccines. Okay. So the next part of the presentation is a little bit about recommended and funded vaccines. So unfortunately, sometimes recommended and funded vaccines don't align. So not all vaccines that are recommended are funded. Eligibility for funded vaccines is based on epidemiological evidence about particular diseases and who might be at highest risk, and which medical conditions would mean that you were at highest risk. More information about this can be found in the handbook and also in the National Immunisation Program schedule as well. So I just thought I'd go through a couple of vaccines and the funding versus recommended vaccines. So I thought I'd start with pertussis because I'm sure you're probably aware that we've been seeing a real increase in pertussis notifications since last year in Queensland. So in the handbook, a booster dose of pertussis containing vaccine is recommended if the last dose was more than 10 years ago for the following groups: adults 65 years and over, healthcare workers, early childhood educators, household contacts and carers of infants, so grandparents, etc., and travellers, particularly particularly if there's a high risk setting that people are travelling to or high risk country. So just to note that none of those dot points are funded. However, pregnant women in each pregnancy and women who recently gave birth and didn't receive a pregnancy funded vaccine are funded. Another thing I just popped down there at the bottom of the slide, I'm not sure if you can see it there, is that just to consider, if someone has a tetanus prone wound and you are going to give them an ADT anyway, and it's been some time since they received a pertussis containing vaccine, that it might be worth considering giving that pertussis containing vaccine rather than the ADT, noting that obviously a Boostrix and Adacel is going to cost them, whereas an ADT wouldn't. But usually I think the private cost of a Boostrix or Adacel is around that $40 mark. So there might be some patients that would be able to pay for that, so that they've also got coverage for pertussis as well. Okay. As I'm probably sure you're aware, all children in the handbook are recommended to actually have 2 doses of varicella vaccine containing vaccine, but we've only got 1 on the schedule. We do see breakthrough varicella, I think mainly because of that, but there's only 1 on the funded schedule. Parents, though, could be recommended to purchase a 2nd dose if they're able to, from a financial perspective. I did a bit of searching up, and it's about $55 for additional dose if you're going to purchase that privately. But it just might be something to recommend or to let your patients know if you're talking to them about varicella. Obviously, after those 14 and above would have 2 doses funded anyway, up to the 20th birthday, as per the catch-up requirements. So when it comes to splenectomy patients or asplenic patients, I actually find that the Spleen Australia has the most user-friendly tool. I just think it's really nicely spelt out. It's an easy-to-use schedule of vaccines funded for those who are considered to be asplenic or have had a splenectomy. So the vaccines for spleen patients are all funded as per the schedule. I just want to make a point about the top link. I know it says antibiotic prophylaxis, but if you click on it, it actually takes you to the slide, the schedule that I've snipped there in the corner for you. So I don't know why it says antibiotic prophylaxis, but if you click on the link, it takes you to the appropriate recommendations for people who have asplenia or had a splenectomy. Now this slide is snipped straight from the National Immunisation Program for medically at risk. It's also actually quite nicely spelled out, I think, in terms of what people need and who would be eligible. And it mentions all of the usual additional vaccines that we give to medically at risk people. Hib, meningococcal, influenza, and pneumococcal as well. I've also added these slides or these snips from the NCIRS fact sheet as well. I just find these also quite user-friendly and all in the one sort of spot when it comes to pneumococcal vaccinations. That can be a little bit tricky as well, just because the differences between risk, at risk, no risk, Indigenous, non-Indigenous, and then age-related as well. And then also on the right-hand side is the list of risk factors. So this is a really good little table because it mentions the vaccines that are, the conditions where vaccine is recommended, pneumococcal vaccine is recommended, but it also indicates the ones that are funded versus the ones that are not. So this is an example of where some vaccines are actually recommended but not funded. So that's the link to the NCIRS fact sheet and also the National Immunisation Program, which has that section on medically at risk. So the next point I want to make is about hepatitis B. So most states, I think, fund hepatitis B for particular high-risk adults, as well as obviously on the National Immunisation Program schedule. So this information is available on the Queensland Health website. So if you click on the code, it'll take you to the website with this information on it. So all household and household-like contacts of cases of hepatitis B are funded for vaccine. Sexual contacts, migrants from countries where Hep B is endemic, Aboriginal and Torres Strait Islander people, people with Hep C and chronic liver disease, as well as injecting drug users as well. So you are able to order hepatitis B adult vaccinations for people who fit into this eligibility criteria. So I know some of you already know this, those of you who are working specifically with refugee health and that sort of thing, but for those refugee and humanitarian entrants 20 years and over, there's a number of vaccines that would be funded. As well as obviously the flu vaccine, which I haven't included in this slide as well, but that would also be eligible for flu vaccine. But if there's no documented evidence for people who are refugees, then you can give these vaccines funded. So I just wanted to include a little bit of information about vaccination as well for, excuse me, for international travellers. It's important to ensure that patients are protected before they travel, and this has become even more important since COVID. So exposure to infectious diseases is part of international travel, and that's because although we may have some cases of disease, particular diseases present in Australia, the risk of actually acquiring them is likely to be higher overseas for various reasons, some to do with things like, sanitation, or to do with the numbers of the diseases circulating in other countries, such as measles that we discussed before. For everyone that's going overseas, that there's not sort of one size fits all in terms of what sort of vaccines are required, and a risk assessment is required. And we would always also ensure that, as well as those additional travel vaccine, travel vaccines that you're associated with travel, that things like MMR, influenza, COVID, and pneumococcal are considered for when you go overseas. And I think we mentioned before about MMR and measles. Sorry to sound like a broken record. And just a reminder as well, sometimes it's a bit tricky because patients sort of come to you about a week before they're going to travel, and then they ask you to have all their vaccines. But it's just important to recommend to patients that they give you plenty of warning if they're going to travel, so that you can make sure that they're getting in all of the doses and the intervals for those doses that they require. And I'm sure you're already aware that most of those other travel-related vaccines, such as typhoid and hepatitis A vaccines, are not funded. Here at the Public Health Unit, we do see typhoid and hepatitis A cases that we follow up here, do public health follow-up on, and by and large, they're from overseas-related exposures. One of the other things that we see all the time at public health is rabies, potential rabies exposures from travel overseas. So prior to any travel to a rabies endemic region, if you want to know where a rabies endemic region is, that's available on the Public Health England and the WHO websites. It tells you what your risk would be depending on where you're travelling to with regard to rabies. So if anyone's going to a rabies endemic region, it's important to provide them with education around avoiding any contact with wild or stray animals or other domestic animals such as dogs and monkeys, and also about immediate wound care. If a patient comes to you post-travel to Bali, for example, and they say they've been to the Bali Ubud monkey forest and they had a monkey scratch their arm, that exposure, what we call a potential rabies exposure, is reportable to the Public Health Unit, and then Public Health would get involved and provide post-exposure prophylaxis, which I know many of you have supported us and assisted us with in the past. There's also now some updates or changes to the pre-exposure course when it comes to rabies. So you can give 2 rabies vaccines for short-term protection if travel is coming up. However, it's important to note a couple of things about this particular pre-exposure regime, that booster doses are required if the risk is ongoing. And it's not suitable for certain doses, such as people who are certain groups, such as people who are immunocompromised, and ID doses are not recommended for people over 50 years of age, because in that age, people of that age group, we're unlikely to get or it's less likely, to get seroconversion from that particular regime. There's some really good benefits in terms of considering possible rabies risk in your patients. It reduces the cost of rabies immunoglobulin. There can be issues with cold chain in other countries if people do have an exposure and they have to be treated overseas initially. So yeah, there's some benefits in considering that prior to travel. There's a really good information in the handbook. There's a whole chapter about vaccination for international travellers as well, if you're interested, or you've got patients that travel a lot in your practice. So I'm going to talk about catch-up now as well, just a few slides on catch-up. We do have a lot of questions in the public health unit about catch-up, and I think that's increasing because, as we talked about before, it's becoming more and more complex. It is one of the most important skills that that you would use in your practice in terms of trying to get children up to date, especially if they've come from overseas, and that's where it can get a little bit tricky. So these dot points are really taken from the immunisation handbook, right at the beginning of the handbook in the catch-up section. So we always recommend that you check overseas history and air history first, and just a note that some vaccines and the age or the intervals in which they are administered is not considered to be valid overseas, depending on the antigen. And with catch-up, we know that minimum intervals may differ from a standard schedule. And we just build on existing documentation. And I've written there's one exception to that, and that's cholera, but I don't think you'll be coming across that too often. And generally, healthy individuals can receive inactivated vaccines at any time before or after, at the same time as other vaccines registered in Australia. Obviously live vaccines are a little bit different, so they need to be given on the same day or at least a month apart to be considered immunogenic and valid. So just a couple of other points from the handbook, that we don't recommend giving 2 combination vaccines containing the same antigen on the same day. So I think you're probably aware that we would usually often recommend that you use a combination vaccine, even if the number of doses of one of the antigen exceeds the number required. So, for example, a child would need a DTPA, a polio, and a Hep B, but they don't need a Hib. But we would often recommend to give a Hexa, for example, or a Vaxelis, even though it means that there's additional dose of Hib given. And that's sort of to reduce the number of actual injections that children require, for example. And it does no harm for them to have that additional antigen, even if they've already had their appropriate number of doses previously. So for some vaccines, catch-up is not recommended, and Hib is an example of that. Pneumococcal, sometimes in children as well, and also rotavirus vaccines, just due to the age recommendations. Just a note to pop onto air that the child is on a catch-up so they can receive their family payments as appropriate. Some of you will be familiar with these resources that I've popped on this slide. So I'm sure you're aware of my colleague Paul. You've probably spoken to him before. He's developed this tool on the left-hand side, the catch-up worksheet. It'll need to be updated now to potentially include RSV in there as well. But that's a really useful tool that might be helpful for you. If you're interested in that tool and you think it might be of use, you can definitely give us an email and we'll send you through the templated tool for you to use. The other thing that I think some of you use, or lots of you use, is the online calculator. Just to note that I think it needs to be used with a little bit of caution for a couple of reasons. One is that it provides information about antigens, which is good, but it doesn't necessarily help you with which combination vaccine to use, and it lists out all of the combination vaccines that have those different antigens in, and it can become a little bit confusing, I think. The other thing that it does is includes the vaccines that are not funded but are recommended. So, for example, on this slide, it's got varicella with the little red dollar sign, which says that it's recommended, but it's not funded. So just a couple of comments about just the use of that with a little bit of caution. If you're confused by any aspect of what that calculator provides you in terms of a catch-up, please give us a call and we can help you. Also, just a note that the catch-up calculator, we've had a couple of calls about this. The catch-up calculator will not include meningococcal B vaccines, because meningococcal B is a state program, not a federal program, and this online calculator is a national program, so it won't include state-funded specific vaccines. So we've had a lot of calls about Bexsero catch-up from when it was introduced by the Queensland government onto the schedule for Queensland. So a couple of notes. Firstly, it can be given from 6 weeks of age as per the Australian Immunisation Handbook. So I think there's been a couple of questions about the product information. So in the handbook, in every chapter, there's a section right at the bottom of every chapter that's called variations. Oh, that's supposed to be variations, not vaccinations. Sorry, variations from product information. So in that section, it gives you the ATAGI recommendations that might be slightly different from the product information. So always go with what's in the handbook. In the Bexsero chapter, there's also a really nice little table, which I'll show you in a minute, that helps you with catch-up. And then just a note, I'm sure you're aware, if you've been administering Bexsero privately or to the Aboriginal and Torres Strait Islander kiddies, that we do recommend that prophylactic use of paracetamol before or as soon as practical afterwards, with further doses required as well, or indicated or recommended. We do usually recommend, if possible, to administer in a separate limb due to injection site reactions. So I've just snipped this table straight out of the handbook in the Bexsero chapter. So you can use this for any sort of catch-up, and obviously it depends on the age of the child when they're commencing. So say you've got a child that's 11 months of age, so you would use the top line. So 3 doses, 8 weeks between the first and second dose, and a third dose at least 12 months of age or 8 weeks after the second dose, whichever is later. Obviously, as the children get older, they do need less doses. Okay. Just a note about due and overdue rules on air, sorry. So not all vaccines attract those no jab, no pay family payments. So for example, meningococcal B and flu are not included in the fully immunised criteria. So because they're not on the National Immunisation Program schedule. I just also wanted to include a dot point here about how to view or where to view your immunisation history from AIR. So a few times we've had a couple of issues or a couple of calls because an error has occurred because people are accessing their vaccination histories from a program that you use at the practice rather than actually logging on to the PROTA AIR register. So what happens is that the AIR history will only go, the vaccines that have been accepted by AIR are the only ones that will go across to best practice. So for example, if you've given a third dose of hepatitis B and you marked it as dose 1 instead of dose 3, it'll come up as incomplete. When actually the only issue is that you've marked it as dose 1 instead of dose 3, but that dose will not come over onto best practice. So there's a risk there that children could be given an additional dose of hepatitis B vaccine, for example, that they don't require. So I just really encourage you to log on to PROTA and check the AIR history rather than utilising some of your other software. Okay. So again, just on the same theme with AIR, so there's mandatory reporting changes. So there's been some changes around all vaccines now are mandatory reporting to AIR. Also, you might notice that when you go into AIR now, there's 2 new drop-down boxes. So one is about, I guess, the funding or whether or not somebody's eligible for a particular funding program. So it'll ask you, there's a drop-down box and it'll ask you to indicate the funding of that particular vaccine that you've administered. And then there's also a new box about the route of administration as well. So I've just popped on this slide some resources that hopefully will be of use to you, mostly from that chapter in the handbook about catch-up vaccination, or little tables and things like that that help you with acceptable age or minimum age and intervals as well. So I'm pretty much finished, and that's lucky because I think I'm over time, so apologies everybody. I just wanted to add our contact details. So here at the Public Health Unit, we all work on communicable disease notifications as well as immunisation. So if you have any questions about communicable disease or notifiable conditions or immunisation, you can contact us on that number, or you can send us an email. I'm more than happy to receive an email as well if it's easier, and then we can either respond by email or give you a call. Okay.
Thanks, Emily.
Thank you.
We've had a couple of questions come through.
Sure.
First one was, just to clarify, when we give flu vaccines from private stock and when we are entering info in AIR, do we put it under NIP or private stock?
Yeah, does it give you the option to put it under a statewide program? Because that would be the other thing. There is a drop-down box. My understanding is that there's a drop-down box for state-funded program on AIR as well. So either, as you've indicated, either private, or if there's an option for you to put state-funded program, because essentially the state is going to fund it in the end, even though it was originally purchased, I guess, by the provider privately. So I would say in the first instance, it should be under statewide program. If that's not an option, then yes, I think you'd have to put it under private, because it's not going to be, the person that you give it to is not going to be eligible for a NIP-funded vaccine unless they fit into those usual NIP-funded vaccine eligibility criteria that we've discussed. Yeah. Okay.
I hope that answered your question, Anonymous. Another Anonymous, I would like to clarify what we upload to AIR, ADT and doctor's bag vaccines as, state or private.
So that's Commonwealth. So ADT, doctor's bag vaccines come from a different, they don't come from the national, sorry, they don't come from QUIP. So they come from the Commonwealth. So again, I would think that the option there would be immunisation Commonwealth, or yeah, probably private. They're not technically state funded because they're not coming by the Queensland Immunisation Program, would be my understanding.
Okay, thank you. Jane has asked, can you please clarify the age use for the flu sorry, I'll spell this, FLUCELVAX, please.
Yeah, so that was what was on, that was part of one of my slides there. So essentially in the National Immunisation Program, it's funded for medically at-risk people from 5 years up to 64 years, where you would use, after that, you would use the FLUAD quad. So where the confusion, I think, has occurred is that there's a sticker. It's come to our attention that there's a sticker on the box that says it can be used from 6 months of age. And I suspect that's related to the fact that it's indicated potentially for that age group, but under the National Immunisation Program, and it does say it on the ATAGI document, on the front page of the ATAGI document, there's a little table around available vaccines and which ones are funded under the National Immunisation Program. It says that particular vaccine is only funded for medically at risk from the age of 5, even though I know there is that sticker on there that says from 6 months of age. We have clarified that with the Commonwealth. The immunisation program clarified that with the Commonwealth, and they did, confirm that it is as per the ATAGI statement from 5 years of age, even though that sticker says from 6 months. So yes, it has caused a lot of confusion, but my understanding is from the advice we've received that sticker is not necessarily going to be changed. So just always refer to the ATAGI guidelines or document where there's that little table on the front page of that seasonal 2024 influenza document.
Okay, thank you. Amanda has asked, do you mind repeating comments about the age details on the packaging of the flu shots? I was interrupted. Thank you.
Oh, sorry, I think that's what I was just.
Oh, okay, sorry.
Hopefully,
oh, okay.
Hopefully that's what it is. If not, send me an email. Happy just use that email at the bottom of the last slide's got the immunisation email, and just say, dear Emily, you didn't answer my question. This is what I meant. That's fine.
Okay, sorry, thanks, Emily. Anonymous has asked, ADT is not able to be uploaded as Commonwealth, so we would assume private, even though the patient or the clinic does not pay for this.
I think so, because it's not a state funded, it's not part of the ordering that you order from QIP. Yes.
Okay. Bronwyn has asked, if logging onto Proda to access AIR, is there a way of changing settings so it doesn't keep logging you out, as it makes it difficult to keep logging on while doing a vaccine clinic, which is why it is easier to use AIR in software?
No, we have that same, I'm not aware of any way around that. We have that same issue constantly. We take a call, and by the time we finish that call, it's logged off again and we have to start again for the next call. I don't know why they have it like that. I'm not quite sure if it's something to do with privacy or something like that. But I mean, any feedback around, we've given that sort of feedback as well about it timing out. But if you wanted to give any feedback straight to AIR, that would be good. So they're hearing it also from the provider too. I know what you mean though. It is really frustrating. We have that frustration here too. I appreciate what you're saying, particularly if you're doing a busy vaccination clinic like you've described.
Yeah. Amanda has just said to say thank you. You answered her question regarding the ages on the flu shots. Sorry, I got a bit confused there. Louise, and I'll just Louise has asked me a question with regards to attendance certificates. Provided everybody has registered for today's event, even if they've all just logged on under one person's name in this clinic and watching the same screen, they will receive a certificate of attendance. However, if they have not registered, I will not be able to provide that certificate of attendance. So I apologise if that's the case in this instance today, Louise, but just for future reference as well, make sure that anyone that wishes to receive a certificate of attendance should register, even if they're just going to be sitting at the one computer with multiple staff members. I hope that made sense to everyone. So that's all the questions we had, Emily. Thank you very much. And I just wanted to remind everyone that evaluation survey will pop up when you go to leave today's session, and we would really appreciate if you could complete that. The recording of today's session and the slides will be certainly emailed through to you guys. It'll take a couple of weeks though, and along with those certificate of attendances. So thanks everyone. Have a, oh no, before we go, sorry, Bronwyn's just asked another question. Sorry.
Oh, sure.
Beyfortus, and I might be reading this wrong.
Yes, yes.
Beyfortus, we will just order specific for individual patients.
Look, I believe that will be the case. I'm not. There's this kind of global supply constraints around this nirsevimab. So it's not clear just yet exactly how it will be provided in primary care. But as you said, I would imagine that it would be ordered, but for individual patients who meet the eligibility criteria. And I'm not quite sure how you're going to be communicating that with the Queensland Immunisation Program. But it'll essentially remain fairly constrained due to the sort of limited stock available. And my understanding is it's kind of going to be a special order process, but we still don't know exactly what that looks like. And more information around this will come out. There's been essentially almost kind of every couple of days, there's been an update to this information. So I would just encourage you to continue to access that website, which is that Queensland Pediatric Respiratory or RSV Prevention Program website, which has the clinical information. And there's a bit about ordering in that clinical information as well, but not the specifics about actually what you will have to do to access that particular vaccine just yet, but it's coming. It's coming.
Okay, thank you so much. Yep, Bronwyn said thank you. That's a great update. Not a problem. Thank you everyone for coming, and enjoy the rest of your day.
Thank you. Thanks everyone. Thanks, Amy.
Okay, thanks. Bye.
Bye. Bye.